So welcome everybody, and thank you for joining us for the next installment of the SIHED Challenge Fund webinar series, hosted by the Council of Deans of Health, with today's webinar being entitled Innovations in Placements and Recruitment. For those of you that don't know me, I'm Caleb Meath, the Policy Officer from the Council of Deans of Health. I'm joined here today by Professor Barry Tolchard from the University of Huddersfield. We will be later joined by Dr. Pete Bridge from the University of Liverpool. Now, for those of you who are unfamiliar with the SIHED program or the challenge funds, the SIHED, or Strategic Interventions in Health Education Disciplines program, was launched by the Office for Students in 2018. The SIHED program aimed to raise awareness in allied health disciplines and raise demand for higher education courses. The challenge funds were part of the SIHED program and represented funded projects which aimed to support the recruitment or delivery of nursing, midwifery, and the allied health professions. The SIHED program officially ended in March 2021, but the Council of Deans of Health have been commissioned to take over the SIHED program as it enters its legacy phase, including celebrating the Challenge Fund projects. As part of this, we'll be running a series of webinars, podcasts, and blog posts with the aim of creating an online resource for those interested in the challenge funds and those looking to run similar programs of their own. I invite those here today to look at the webinar we hosted 2 weeks ago, which can be found on YouTube or on our website, along with the other resources. As I mentioned earlier, we are joined by Professor Barry Tolchard and by Dr. Pete Bridge, who will be making their presentations, and then there will be some time at the end for Q&A from the audience. I would therefore invite the audience to pop any questions they may have into the Q&A box at the bottom of the page so that we can collate them for the Q&A later on. So without further ado, I'd like to introduce Professor Barry Tolchard to speak about his challenge fund. Professor Tolchard is the head of the Department of Nursing and Midwifery at the University of Huddersfield. Over to you, Barry.
Thank you very much. And I just want to warn people not to get too alarmed, because with the open window behind me, squirrels and pigeons often come in on that windowsill, so they might jump straight through the window. So don't be alarmed if they come through. It hasn't happened yet, but I've seen them nearly do it. So we'll watch out for that. I'm just going to put my presentation up. Oh, I've got my screen sharing all messed up on me there. Right. Okay. Oops. Okay, so the work that we did at Huddersfield was centered around a kind of a broad community engaged community engagement and community scholarship kind of model, which is a common model used in other parts of the world, particularly America and Canada and Australia. And the idea is that the model is based on this idea that what we teach and what we learn and what we research and how we engage with community is kind of all part and parcel of the same thing. So the work, from my perspective, started over 20 years ago when I've worked in Adelaide and then Hawaii, where we actually started doing high ropes courses with student nurses and mental health service users, and they all camped and lived together for 3 or 4 days and cooked together and all learned to trust each other on high ropes courses, which was very interesting. And then moved on to working in an Aboriginal health centre in Tamworth in New South Wales, and then with refugee communities in Buffalo, New York, finally in this country, to looking at a mental health recovery service and this Huddersfield student-led collaboration. And each one was building on the same principles and using students as the direct activists of this work. As I've said, it's based on a model called Scholarship of Engagement, developed by a guy called Boyer, Ernest Boyer, and he was talking about how we can connect the rich resources of the university to our most pressing social, civic, and ethical problems to our communities and our cities. And the idea was to educate students as responsible citizens instead of just career-only kind of minded people. So therefore, we do move beyond just research, teaching, and applied knowledge in separation, but bring it all together in this thing called Scholarship of Engagement. Now, what was it we did? It was an opportunity for students from all disciplines across the school. This is the School of Human and Health Sciences, but in actual fact, we drew students from the School of Science as well, Applied Science as well. Oops, sorry about that. Because we have ophthalmology in that school, and they were part of our initiative as well. So therefore, we had a steering group of all these people, including community members. That included the councils, the health services, the social care services, and some private and voluntary organisations. We included all these disciplines, quite a range of disciplines, as you can see, including, interestingly, police and psychology students. In Huddersfield, all students have to do a 2-week placement, regardless of their course. And our police students were, as you would expect, very good at marshalling the audience and marshalling the crowd and bringing people to us, which was quite interesting, and they really thoroughly enjoyed doing that work. Here's all the different organisations that were involved. So you can see we had National Health Service groups, primary care groups, the council, the police force, and community and other services. So we had quite a range of organisations that we were working with. We had direct agreement from the 4 major trusts that we work with, which are Mid Yorks Trust, Caldale and Huddersfield, South West Yorkshire Mental Health Trust, and Locala, the PCT type trust. What we did in this programme was we chose an activity to be the kind of the catch point for all of the engagement. And in our case, we chose the activity of doing a basic health check. And within that health check, we also asked a bunch of questions of participants, and were able to get a sense of their well-being and their general health overall. But as part of the using this as the capture part, what we then did was the students from different disciplines would also be there, and they would provide similar work to their work within their own disciplines, but would also get involved in the health check work depending on what was going on. So for example, we did have optometry doing eye tests, we did have podiatry looking at people's feet, we had operating department practitioners doing CPR demonstrations and all sorts of things going on. But the central tenet of our work was always these health checks, so that we had that one consistent thing throughout. The idea here, therefore, was to promote wellness in the community. This needed to be a long-term, sustainable activity. And so we were going to try and look at promoting wellness in people within Kirklees. And Kirklees, as people who may not be from the area, consists largely of Huddersfield and Dewsbury and some smaller towns in between. So the students offered the health checks and well-being checks to these public venues. And engagement activities largely happened within vulnerable groups or hard to reach groups. I think vulnerable is the wrong word. Hard to reach is probably a better. Those communities who are less likely to attend normal clinical practices is the kind of groups we were working with. People were able to access our survey via website online, and we had a whole bunch of services who sent out our survey to these groups. Again, I've used that wrong word, vulnerable again, it is. The hard to reach groups were then targeted through different partnerships. And the data was actually was fed back to participants directly. So when they completed the forms, they got a RAG rating kind of thing of amber, green, amber, and red about how their health kind of came up. And that was both in terms of their physical health and their mental well-being. And then later we were using a thing called the EuroQual, which is a quality of life measure. And we added that in because it was part of the feedback from participants that they would also like to see how their general health was able to be looked at by these students. And here's kind of some of the outputs that came from the questionnaires. I know you probably can't read that very well, but you can see on the left-hand side, the mental well-being scale has a national database where you can compare your population against the national population. And that therefore shows you whether people fall into the top 20% or the bottom 20% and so on. And as you can see here that most of our participants on average fell into the average level. However, the people at the Murfield show, which is a country show around here, were slightly in the higher percentile. And I think we might put that down to the fact that there was lots of fun and activities going on that made them all a lot more cheerful on the day, which was nice to see. But on the right-hand side, and you can't actually see the names there, but you can see in the red, there are still individuals who were rated in the red. And I mean, this is, and the red was a marker for us to provide some additional signposting or extra support. And those people would be taken off to one side, and we would talk to them and spend more time with them. If anyone was in a position where we thought that their health was at serious risk, we would directly manage that. And a good example, not from this group, but from my work in Australia, we did have to put someone in a cab and send them straight to A&E because their blood pressure was so high. We couldn't actually understand how they were walking around. That person did very well. They got help and were fine. But we had no one like that in these services. So that was good to know. A second part of the work we did was a bit of the promotional stuff, because this was centered around trying to help promote some of the less well-known courses like podiatry and ODP, and learning disability nursing was another good example. So on another occasion, we had students who actually did direct teaching to school kids, and this is the outcome from the teaching to school kids. So they were taught how to use the same health check equipment that we were using on participants in the activities. And then we asked the students pre and post how they felt their confidence and competence in using those materials were pre and post the teaching by the students. And obviously that was used as an opportunity for the students to explain what their programs were, what they were doing, what the courses mean, how the students might want to get involved and so on. And we followed that kind of work up by obviously direct work in schools and colleges and various other places, as a lot of universities would do. That was a reasonable improvement over a very short period of time. We didn't bother to test that months later, but if we had, I suspect it would have probably been much the same. Some of the things that were beneficial to the students, the placement hours were credited for every event. It was an experience that could be used for people's CVs. It certainly built a lot of confidence and communication skills amongst the students. And it gave them access to a variety of people from different backgrounds that they didn't necessarily get in their normal placement practice. And it was given back to community, and we got a lot of good comments, things like that the community was saying they felt like they were helping the student as much as the student was helping them, and that relationship was really powerful at times. Of course, people had fun. You can see that that's the Murfield show, so we were outside on a day like this. In fact, it was probably much this time of year we were doing that show. And a lot of students talk about how it was being part of something amazing. It was something just quite different from the way we normally do things. Here's some good examples of some of the activities that went on. You can see here, I don't know if you can see my mouse, but we did have Santa Claus and his elf on one occasion. And this was the actual mayor of Huddersfield getting his health check done as well. But we had a whole range of different people participating in the health checks. So the fundamentals of this is that how I describe this is mobilizing the transdisciplinary multi-agency collaboration. So it's basically about getting everyone together and just doing some good in the community. And that's what I think we probably did. We did bring lots of local services in the council together and work as one. We created this kind of mobile placement where students could go and they could just roll out and provide these kind of services at the drop of a hat. We did reach community members who traditionally wouldn't normally seek that kind of help. Students did initially volunteer, but now it's become a standard part of their program. In fact, in nursing in particular, and in occupational therapy and physiotherapy, there's a rolling student-led clinic that now becomes part of their standard clinical practices. This is all centered around the development of what we're referring to as the Health and Wellbeing Academy, which is part of the university's more concerted civic outreach that we're trying to do into our local community. The future, as we said, there will be activities weekly once we're able to get back out into the world again. We do have secured a service, a place in the centre of Huddersfield where that will be our permanent building, but we will keep going out to different parts of the community. And on one occasion, we were going to go take a bus on a bit of a rolling road trip to different parts of Yorkshire, and that was particularly to work with people with learning disabilities and provide health checks and support to them. So we were going to do each of the 4 Yorkshire county parts and do a road trip to all those areas. We definitely did work with a lot of vulnerable, I I don't know why I put that word vulnerable, and people have to yell at me after that. They're harder to reach groups, and that was very positive in that we were able to do that. The focused events that are also planned is we're going to look at doing more broader health promotion kind of sessions. And in actual fact, towards the end of earlier this year, we did our own webinar on Heart Day. I can't remember, it was earlier this year, just before Christmas, but we did a webinar where we provided a service to the community and talked about heart health and various other things on Heart Day, and we turned our buildings red and did all that kind of stuff. We also did a few events around the year of the nurse and midwife in a similar vein. But moving on, we're going to do more on online engagement because that seemed to work very well. So the mental health, OT and physiotherapy coaching through the Huddersfield Wellbeing and Thrive clinics will continue. We have a student-led podiatry clinic, which is expanding beyond providing work just in the university, but it's becoming part of the mobile clinics that we operate. We are established in this Health and Wellbeing Academy through the Northern Health Innovation Campus, which is involving Huddersfield building a new health building on the outskirts of Huddersfield itself rather than on campus. So it'll not be too far away, but it'll be seen as a distinct health offering by the university that's linked to the town centre. And we definitely will be returning to the outreach and on-campus community engagement activities that we have done a lot of. And just to finish off, even though I was telling the organisers before we start that I'm actually moving from Huddersfield, I'm moving to Teesside University. Teesside and Huddersfield will operate a joint memorial fund, which comes from funding that I've brought with me, and we'll carry on the collaboration, not just with Huddersfield, but I'll take that collaboration on into my new job as well. And here's just a kind of an analysis of all the things participants said about our students, and you can see the biggest thing that comes up is the word friendly and nice, and as the experience was positive and it was welcoming and so on. So I think overall it was a really useful and an experience which is definitely going to continue on. That's my final slide. Thank you very much.
Thank you, Barry. Very informative project, and I think it's a really unique project as well, and sort of speaks to kind of the topic of the webinar today. So thank you for that. Seems like we're having some good questions rolling in, so I'd invite people to keep popping those in the Q&A box, and then we'll ask them all at the end. We can ask both of the presenters. Right, we'll move on to Dr. Pete Bridge. Glad to see you made it here all right, and everything's going well. So Dr. Pete Bridge is a senior lecturer for radiotherapy at the School of Health Sciences at the University of Liverpool. So over to you, Pete.
Thank you very much, sir. So yeah, apologies. You never know what the traffic's going to do on the M62. It could go either way. Fortunately, it was going the other way. So thanks for the invitation to speak. I'm going to talk to you about really, we had two challenge funds projects. The first was very much related to radiotherapy, and that's my background. I'm from the therapeutic radiography team. And the second was about extending the findings from that to a much wider remit across the School of Health Sciences and a lot more of the allied health professionals that we train. So I start by acknowledging that it's not just me, there's a vast team behind me. So there's myself and Sarah Jane Ketterer led the project together on behalf of the radiotherapy team, and in fact, on behalf of the whole School of Health Sciences at the university. So a little bit then about the project to start with. So the first project that we did investigated the feasibility of running a simulated placement on campus in radiotherapy. And the reason behind that was we know that people use simulation as discrete little activities to prepare students for when they go out into placement, or to give them a little bit more training in regard to something you've just learnt about. But what we wanted to do is see if we could use a range of simulated activities to replicate as close as we could what happens on clinical placement. So the first project, we randomized people into 2 groups. One had a 2-week academic-based simulation placement. The others had 2 weeks clinical placement. And then we swapped them. And in the middle, we gave them all the blinded clinical assessment, and we saw equivalence of performance, and in fact improved performance in interpersonal skills from the simulation group, which we weren't expecting. So this project then really wanted to extend that out and see, to answer the question that there wasn't really an answer to in the literature review, which is how much can we replace clinical time through simulated placements? And that, the literature has got a vast range of answers to this. So some authors have proposed 50% replacement of their overall training time with simulation. Some a lot more cautious, and some of the early work really was saying, no, we don't want to do it. That was a lot of feedback from clinical staff. So our primary research question was to find out the extent to which a simulated placement can be used for partial replacement of clinical placement. It's a lot of the word placement there. So I tend to shorten that to PRCP, partial replacement of clinical placement. We also wanted to establish what the benefits and challenges stakeholders associated with this idea, the concept of a simulated placement week. So we used the funds along with matched funding and support from mainly virtual reality software vendors to expand the simulation facilities at the school. In the background image there, you can see one of our radiotherapy simulations. There's a big VR screen at the back. And one of the problems with that is, of course, there's no patient, it's all just a screen. And we've got an actor here on a treatment couch with the setup equipment, and we've got a tutor there showing a student the correct position. And that enabled us to combine the two together. So that was a really effective use of the resources. So you can see they're all in uniform there, and we made sure that people followed a rigid rota, had breaks, they had to wear appropriate things, put their mobile phones away. That didn't go down well, let me tell you. And we ran through some very realistic patient cases using actors and using a range of service users and tutors. As the pandemic sort of took more of a grip on the project, we moved to more online videos and using previously filmed materials from simulations and getting people involved in sort of telehealth simulations as well. Well, the key point really, what I really want to share with you today is the evaluation from that. So we had all of our 6 professions within the school, so diagnostic and therapeutic radiography, nursing, orthoptics, occupational therapy, and physiotherapy. And each of those had some form of a simulated placement and gathered their own sort of version of profession-specific feedback. But really what I wanted to talk about today is the second arm, the big arm really, which is the Delphi project, to try to get a consensus opinion from a range of stakeholders about how far we could feasibly push partial replacement. And make no mistake, none of this project was aimed at eliminating clinical placement. It's all about seeing how we can reduce the number of clinical weeks and still deliver excellent clinical skills training. So some of the successes and difficulties associated with that. In terms of success, we definitely got a good flavour from the SIHED project that of interprofessional collaboration, and there was a lot of support for that, and we were able to engage really good networks, particularly from the output of our first project. And that led to some really good interprofessional resource development, and we encouraged students to sort of cross-fertilise and get involved in each other's simulations. So we had some students pretending to be nursing student patients, and we had some nurses coming along and learning what the requirements are for someone being imaged. So it was very rich resource development. We did a lot of collaborative learning, and we made heavy use of service users to steer what kind of simulation activities they thought would be best suited to match their requirements as well as ours. As I said before, we felt that we managed to transform quite well to respond to COVID-19 and move online, and we had a reasonably good engagement with the Delphi. Now, I'm not sure if you all know what Delphi is, and I don't want to be patronising, but a Delphi project is a means of gathering a large amount of opinions from informed experts and stakeholders. And the way Adelphi works is that you initially ask some fairly open questions about something, you gather some responses, and then you start to build up a pattern of this is what most of you think, this is the consensus. And how it works is then that there's a series of iterations where you present that consensus data and ask people if they want to change their mind based on the evidence and the consensus, and hopefully you see convergence of people's opinions. And what you do find is that and what we found as well, is that you get this convergence towards this opinion that is then representative of a very diverse group of individuals. So it's quite a powerful technique. You probably can't see a huge amount of detail there, but we covered we really want to focus on the 6 professions that we taught in the School of Health Sciences, but we invited other professions to feed in there as well. And we also made sure to get a spread of experts from a range of different roles within their profession. So service users, academic and clinical managers and professionals, researchers, and people in charge of simulation facilities. So we wanted to capture as much diverse expert opinion as we could. One of the drivers for that is an early piece of work by Kerry Thoyers over in Australia, where they conducted a similar sort of project, but they asked clinical staff what they thought about this exact issue. And they got a lot of feedback saying that you can't teach students anything outside the clinical environment. All clinical skills training must be done on placement. So we wanted to kind of test that in the light of a lot of new evidence, and also the capability we've got with new software and new hardware as well to actually deliver a simulated placement. So here you can see the rounds. We ran 3 rounds as planned. And you can see this issue of convergence here as we move from round 1 and 2 and 3. You can see more people kind of converging around that 11 to 20% mark, with a secondary 21 to 30%. So we can say with a reasonable amount of confidence that between 11 and 30% of clinical placement time could potentially be replaced by simulated placement. And I don't mean by little ad hoc simulations. This is by a well-planned simulated placement with a series of actors and events and scenarios that are very realistic. Interestingly, you'll see that the people who are really keen on delivering over 50% through simulation really kind of maintained their stance all the way through. So they're very passionate about that. Whereas the ones who are at the lower end, so 0 to 10%, they tended to adjust further up to think, oh, actually, maybe there is real good value in this. There were some challenges, and key amongst those are the quite horrendous logistical challenges of replicating a bustling, vibrant clinical placement on campus. So we had to plan a lot of activities that maybe not entirely the same, but cover the same learning outcomes and enable them to test a breadth of skills, and also, importantly, to get that collaborative teamwork environment set up as well. So that's quite challenging for large cohorts, and some of our cohorts are reasonably large, shall we say. So we needed a lot of sessions and parallel sessions within that, and splitting our tasks amongst parallel sessions even within those. So we needed to make sure there's enough time per student. That really is so challenging. It's within a clinical environment, you've got a lot more capacity to put people into a large number of different individual scenarios, whereas we're trying to condense them into a relatively small space. And to be fair, it did cost quite a bit in terms of resources. We had support from SIHED, and we already had a lot of the facilities in place, but buying in actors and tutors just to make it that realistic environment can be quite challenging. So we're just talking about our experiences working with SIHED, and on the whole, these were really, really positive. We really appreciate the financial support, particularly for our first project, which was the first of its kind, really, to try to do a randomized controlled comparison of simulated placement with clinical. Without that financial support, we simply wouldn't have been able to do that, because we had to run our teaching time after time and build up a huge amount of resources very rapidly. But now they're available, and we've always been happy to share these resources. We've always made it clear that we share these resources with other HEIs, so do let me know if you want some. The regular reporting we found not too onerous, but it did help keep us on track, which is really useful. And there's been loads of opportunities to share through the networking events such as this. and those that came with SIHED to really meet other people and get some ideas from them and share our ideas. And I think we've still got some collaborative opportunities that we're going to take people up on very soon. So I'll just briefly then mention what we actually determined from our efforts. So the big finding, and I'm really only presenting a tiny bit of the whole work here, but the big thing was that most people felt comfortable replacing between 11 and 30% of clinical time with simulated placement. Now, there are some real ramifications for this in terms of placement capacity. We've put some things down here about the sort of caveats that these are the things that we found really needed to be in place in order for this to be effective. But when we come to look at what happens in terms of using these simulated placements, you've got to remember that there's these two key drivers at play here. So on the one hand, you've got the idea that, well, if we put people into simulated placements, then they're going to get a better clinical experience because they'll be better prepared, and we can spread them out amongst the available places, and everything will be better. We'll reduce the training burden on placements. And then on the other side of the coin, you've got the need to get more and more learners through the qualification process. So all of a sudden, oh, well, we can fit more people into this gap. So you've got that trade-off constantly of, do we use a simulated placement in order to put more people out into clinical, or do we use it to give them a better experience and reduce that training burden? And where we sit on that balance, I think, depends on your profession and also a lot of other drivers that relate to your own clinical practice in those scenarios. So we asked people their benefits and the challenges associated with simulated placements. And again, we wanted to achieve consensus with which were the key factors and drivers here. So the reasons why people felt that partial replacement was a good idea related to exactly this issue, this trade-off. You can either reduce the training burden, or you can just hoof more learners into the department and increase the capacity. And both have got their plus points, of course. The second one was gaining core skills. And there's an acknowledgement there that sometimes, particularly for early learners, sounds wrong, doesn't it? It's like the early learning centre, but early years students, again, sounds wrong. First years have to pick up a lot of stuff that's quite basic that we can deliver really well in an academic environment. And it does make sense to make sure that when they're out on placement, they actually have got the skills already to be able to engage with patients, which is the one thing really a simulation can't provide, and they'd be able to operate safely. And that really links into the third and fourth points, really. The third was that there was a very strong feeling that it was a safe environment where you could learn by mistakes. And certainly I remember we threw our first placement students into a communication scenario with an actor who was portraying someone who'd just been told they've got a month or two to live. And this is a cheerful actor guy came in, right, what am I doing? And as soon as he came in the room, it just looked like death. It's monosyllabic, but a little bit aggressive under the sort of doom and gloom that he managed to portray beautifully. And what the students got out of that was that we'd never put them in that real situation, but they responded as if they were. And we'd stop, pause. I didn't want to say that. I should have said that, and rewind. And that pause and rewind scenario was a really powerful learning for them. So yes, we're able to make sure they've got an idea of how to work in a safe environment by letting them learn through mistakes. Better prepared students, and we certainly got some feedback from people that it does speed up their learning in terms of clinical placement. The time we invest in a simulated placement week reaps the benefits when they then go out on placement, and staff go, well, they actually know all this already, so we can work on some higher level activities here. And fifth, of course, we weren't expecting this, but it did help COVID-19 restrictions. It's designed for small group work. So a lot of the resources and things that we'd already got in place, we've been able to use right the way through, because they're kind of designed for very small bubbles to participate in. So that actually worked quite well for us. The challenges then, the biggest one that people saw as a hurdle was that there were no patients involved. And that really reflects what Thoyers et al. Found in their Australian work. And there's no way around this really, but in many ways, that's the point, is that you're able to practice before you go out onto the working with patients. It's like a flight simulator, isn't it? The big challenge and disadvantage of that is that you're not actually flying, but you learn to fly and then you practice with sky and gravity and all those unpleasant things. The second one was the unrealistic environment, and your students know they're in a simulation. It's impossible to get away from that. But provided the scenarios are realistic and the ways of working together to address those scenarios are realistic, and that's really what we invested in, that didn't seem to be as big an issue as we felt it was. And bear in mind, our Delphi participants hadn't all had an experience of a simulated placement. They are going off the evidence base and what we were able to share with them in terms of our findings. The third challenge was logistical, and yeah, we accept that, it was. Some people felt that it could hinder interpersonal skills development. And I think a lot of that just stems from the misunderstanding in many cases that a simulation involves blowing into a dummy or trying to inject into an orange and things like that, where there's no patient absent. And a lot of the resources and facilities have moved on quite a lot since then. And we've invested a lot of time in our simulated placement to focus on interpersonal skills development. And indeed, the first round of the project that we did, our simulated group outperformed, statistically significantly outperformed the clinical group in terms of their interpersonal and communication skills. And finally, lack of buy-in. So again, echoing the Thoyer's paper, really, a lot of issues related to clinical staff going, I don't like this, it doesn't feel right. And occasionally that can feed through to students feeling they're not getting proper training. So some misconceptions to clear up there, I think. Okay, nearly there, I promise. We can conclude really that from a student's perspective, partial replacement of clinical placement can reduce their logistical and financial burdens. And that was a key part of this project, particularly when we look at mature students who, in our profession anyway, often are placed a long way from their homes. So I know for some professions where you've got a lot of practices around a metropolitan area, it's quite easy to have things at an easy commute. But some of our students have to commute from Liverpool up to Carlisle, or Manchester and Liverpool's not so bad. But sometimes there's quite a large commute involved. So this can make courses more attractive to mature students. We're looking at the longitudinal data at the moment to see if that is actually going to impact. We have also found that they're really good recruitment resources. So being able to show people a section of a simulated placement really gives them a good flavour of what is happening. And we videoed one of those. And of course, that's been useful when our placement providers stopped doing clinical placement site visits as a part of the COVID response. And we also have data suggesting that the better preparation for placement delivered by simulated placement weeks increases our student satisfaction and reduces our attrition. But again, we need to wait to see the long-term effect of that on our cohort. Okay, currently we're still ploughing on with our simulation, and we were able to throughout COVID-19, and having the small groups in our large simulation labs proved very popular with students who finally got to meet each other, engage with their peers and lecturers. And we've just finished a week of a revision placement where our students who failed some clinical elements have been able to uptake a revision simulated placement week. And that's proved really useful. Thank you very much. Acknowledge the rest of the huge team at the School of Health Sciences, the simulation champions, obviously SIHED, thanks for the money, and Industrial Partners Virtual Shaderware, thanks for the software. Thank you for your time and listening.
Thank you, Pete. Once again, extremely informative, definitely speaks to the sort of topic of the webinar of innovation, especially considering how you said the literature really wasn't there beforehand. So it's really sort of breaking new ground, so to speak. Right, I guess that brings us to our Q&A session. Thank you for everybody who's asked questions. They've been pouring in throughout the presentations. I've just had a chance to look through some of them, and yeah, some of them are aimed at individuals, but I'll try and get sort of a blend of all of them. Also, some of the questions about sort of availability of resources, we'll try and make everything available that's possible, assuming Pete and Barry are fine with that. You might find links popping up somewhere at the end of this. I'll just get started with one, which is a little bit more broad that both you can speak to. So we have a question that says, for universities without the existing resources, do you have any recommendations as to how we could implement something similar?
Do you start, Barry, or shall I?
I don't mind. I mean, in terms, I can start if you wish. In terms of the work I'm describing, I've run these projects with no resources whatsoever. I think it's just about getting the goodwill of people to collaborate with you and just push with it. I mean, the work, for example, we did in Tamworth in New South Wales, we started off just going into fields and putting up tables and bringing people in, and then eventually we worked up and worked up and worked up. So yeah, the resource thing is always an interesting question. I'm certainly one of these people who I thank SIHED for the money as well, but I rarely spend the money when I get the money because I always get people to give stuff for free. and I think that's kind of what we did spend your money, by the way. Yeah, the resources, an interesting one. It's I mean, we got pharmaceutical companies and medical companies to provide some of the kit for free and things like that. So we kind of just went around and made people do stuff and tell them how good they were being for doing it, pretty much.
Cool. We did actually poach a lot of secondhand kit ourselves for some of our simulation activities, but yeah, I definitely identified that actually in starting these placements off can be quite costly. So we invested quite a lot of the money into preparing sort of scenarios and patients and cases, building some cases that the students could get their teeth into. And once they're prepared, really, a lot of the work that we did, there's always people saying, oh, there's high fidelity, which costs a lot, and low fidelity, which doesn't. And people tend to think that the high is better than the low. But a lot of the stuff we did for interpersonal skills simulation, you couldn't get any lower fidelity. It's putting humans in a room with a scenario and letting it progress. So I think you could go wherever you want with the simulation investment. The key, I think, is to get a broad mixture of things, and really to start resource sharing. These scenarios and these patients, we're happy to share with other HEIs. And I think if we can get to a more sort of collegial place with those, I think that'd be really helpful.
Thank you both. This next question sort of leads directly from what you were just saying, Pete, and I'll expand it a little bit so it applies to you as well, Barry. So the question is, have these results led to programs increasing their use of simulation? And then for Barry, have you seen as a result of your project, other HEIs or other providers doing similar things as well, or is it maybe too early to speak to that?
Do you want to go first this time, Pete?
Why not? Thank you. Yes, we've used loads more since the project started. So I just talked briefly about the revision placement. And previously for referring students, it's been really hard to, because our clinical placements are solidly booked. I'm sure most people's are. It's been really hard to find them additional time to catch up on their clinical skills training. So being able to bring people who were referred in a clinical placement onto campus and give them that clinical skills training, that additional sort of brush up time, really, really helped. That was something we didn't do beforehand. And that's partly due to COVID, I suppose, but partly also we had the facility, literally, to be able to deliver that. In terms of collaboration, yeah, we've shared our resources with a couple of HEIs in the UK already. And I say that the door's always open to do that. We very much believe that we've been paid to do this, so really they kind of should be in the public domain, and I think that's somewhere where the simulation community really could go. I can't remember the other half of the question, but I think that was more for Professor Tolchard, was it not?
Yeah.
Yes.
Okay, thanks. Just to say that the student-led stuff fits in nicely with what you're talking about, because it's part of our simulation student-led placement. You know, it's all part of a continuum of that kind of work. So the two would actually complement each other quite nicely, I think.
Yeah.
as you said, yeah, is it too early? The pandemic didn't particularly help because we were just about to launch into other areas. As I've said, because I am moving to another university, I've already said the only reason I'll move to that university is if I can continue with this work. So that will certainly happen. But there is an entire international student-run clinic group that regularly collaborate with one another, and this is now feeding into that because I'm part of that group. So yes, in that respect, it's certainly collaborations are big thing. But I saw the collaborations from our end more the collaborations with community rather than necessarily other HEIs, because we were bringing more and more community groups in as part of that collaboration. As part of our university giving back, and then that model can quite easily be translated to other HEIs who want to do that.
Cool. Right, our next one is, I'll kind of combine a couple of questions here. So it's for both of you, it's about how you manage the external relationships that were required for these projects. So for example, how did Huddersfield manage NMC supervision requirements for the community engagement projects, but also any sort of external, with simulation, you obviously have a lot of different technology companies and that sort of thing. So how did those relationships get managed? I guess, Barry, your turn to go first.
Okay. The NMC supervision, there was no issue whatsoever because there was always an NMC qualified person on site. Even though they're a student-led clinic, there are still supervisors available. All we do is we just don't hang out with the students. We let the students get on with it, but we're always there to supervise, and therefore that supervisory element is part and parcel of what we do.
I think for us, there was an already existing enthusiasm, particularly from simulation manufacturers, to use the kit. And I've had anecdotal conversations with people who go, "Oh yeah, simulation. We've got a cupboard somewhere full of like £10,000 mannequins. Yeah, but we never use them." And I think there is that people think, "Oh, we need to do simulation. We'll buy some shiny toys," and then they don't know how to use them, so they don't get used. So certainly the manufacturers were very, as you can understand, very keen to see their products actually get a good thrashing. In terms of other external relations, we already have really good contact with service user groups. And again, they're incredibly enthusiastic about any opportunity to input into student education. So they were really, really good. It's not even an issue, but the only things that we had to pay for were the actors, really. They don't work for free. That's their job. So we couldn't really say to an actor, "Why don't you come and help cancer patients?" No, they needed paying, but they were wonderful about it. And the good thing about them is they're happy to pause and rewind. They can change into different people like that, and they don't change their script. And when we've worked with service users before, they've kind of learned what the students need to be saying and coached the students during assessments. So I think I went off topic there, but it wasn't a problem. We dealt with that. Thanks, Caleb.
Good to hear, Pete. This next question is, were there major differences in operating in different national systems, Australia, America, compared to the UK? So I know both of you spoke about the different national context of this. Barry, you've definitely worked in those different contexts. Is that something where there was major differences that you experienced, or not so much?
There's always a major difference between anything you do in America and anything you do anywhere else. Australia was kind of the same. What I can tell you is the biggest barriers we found were here in the UK. America and Australia were much more open to these ideas and much more open to student-led clinics than the UK has been. But the UK is changing. I think the UK is beginning to see the benefits of these kinds of things. America's biggest problem was, and I saw there's a question earlier on, was the issues around insurance. And you had to find a way of getting around that in America. We had to find a way of getting around that in this country, but our university has such a massive insurance cover that it didn't matter. We were covered, and the clinicians have their own insurance, which covered them as personal practitioners as well. Anyway, so that was a big issue in America. If you couldn't get the insurance, then the risk sometimes was seen as too high. But Australia, as you might imagine, was, yep, go ahead and get on with it. Let's make this work, and they were really open to everything and anything you could possibly throw at them.
Cool. I don't have a lot of experience with the US. I did work in Oz for a few years. I do have something to throw in here, though. We during the COVID pandemic, of course we had massive restriction on our clinical placement capacity. So we kind of felt we were probably all right because we were using our simulated placements quite effectively, but recognized that a lot of others weren't. So we actually convened an international online conference specifically for medical radiations. This was so diagnostic and therapeutic radiography. And we got people to share their practice with each other. So it was a big free event. And we got about 1,000 people attending that. And there was a lot of enthusiasm for resource sharing and for working in that same way. And that involved a lot of countries. So I think, yeah, there may be different ways of working, different practices, those kind of things. But I don't think they're as great as some of the difference we've got between our different professions. And when we looked at the partial replacement issue, there's very different perceptions between our different professions as to what constitutes simulation and also what they felt about partial replacement. And you look at some of the recommendations for different professional bodies here, they're very substantially different. So there's differences everywhere. I think we can overcome them though.
It's interesting, I'd follow up on that actually. One of the barriers I did come up against was our different courses and how it would fit in with their course. And I think that was something which people struggled that it doesn't have to fit in with a course necessarily. It's something you can just do because it's part of what universities do. And once we got past that, things worked really well.
Yeah.
Great. I think we're coming near the end. We've got two more that we'll get to. A couple of questions were about kind of specific details of how the projects went. So one of the earlier ones was how many placement hours did students typically undertake? And then one said, for Dr. Bridge, was a simulation used to sign off competencies which would otherwise have been completed in the clinical setting?
Can I jump on that straight off? That's a beautiful question. And that's somewhere I think simulation is going to go. There are some published examples from my field anyway, of people actually signing off competencies based on simulation. But I think at the moment they're the brave few. Our sessions were very much around better preparing the students for an actual clinical sign-off. And I think that's where the resistance from clinical staff would definitely come from, is if people are being signed off as clinically competent without actually having done that with a patient. So I think when our simulation gets more sophisticated, potentially we could see some aspects of clinical skills being signed off using simulation, but that's an area I'm really interested in researching further. So if that question has got more to it, please let me know. I can't remember the first half. Sorry, I got distracted by that because I love it.
Just to talk about the hours, these are mobile. If you describe them as a mobile student-run clinic, whether it was on campus or it was out in the community, the function of the clinic was the same each time. So we audited that. So therefore, it fitted within placement hours. And there was two opportunities. Some students did it as single days as catch-up placement hours, and some students did it for periods of time. And during the pilot phase, this phase that this money was based on, they were doing kind of 2 weeks if that was what they were doing. But we've now moved to 4-week placements doing this kind of stuff.
Cool. I just add as well on that, we since we did the very first project that showed equivalence of the student learning, we changed our course calendar and dropped 4 weeks of clinical placement, and we've introduced 4 weeks of simulated placement, and the student response has been good, really good for that. So we've kind of integrated the simulated stuff within the main academic blocks and given them a bit more of a holiday. So it's kind of worked both ways, that really.
Perfect, thanks guys. And I'll just leave off on a question sort of looking towards the future. So I guess that kind of speaks to it. What is the future of these projects? Is it something where the projects are already in a good place to go forward? I know, Barry, you're obviously moving institutions coming up, but is it something that needs significant investment going forward, or are these set up to sort of thrive already?
I mean, my answer is a bit of both, really. I think there are some universities which have a very strong civic agenda in their kind of strategies these days, and I think that will move a lot of this kind of work forward, both in simulation and in student-run kind of stuff. As you heard, we're opening up a brand new building with a health and wellbeing academy that will manage all these kind of things, and we will certainly be running them forward.
So we're quite keen to start to influence professional bodies and societies, and that's really, I think, where we're gonna see the biggest impact of our work is in redefining how we monitor student progression. And that really, if we look at the difference between the UK and Australia with a little parallel, when we learn to drive in the UK, if we can drive as soon as we've turned 17, because we've been driving around a farmer's field since we were 10, you pass your test. But in Oz, you've got to put the hours in. And whether you can pass or not, because a lot of the kids out there, certainly in Outback, will be able to drive really better than me by the time they're 14 or 15. You still got to put the hours in. And there's a bigger question here, isn't there? Is that do students need to put the hours in to become competent, or can they just become more competent? So that's the kind of conversations I think that this project might start to see being phrased more. So we're taking this work, the results of this work, to Advanced HE's NET conference this year. We've got a symposium on this, and we're hoping to engage in some vigorous debate about this topic. But yeah, certainly we're going forward.
Yeah. As you know, in terms of nursing and midwifery, student nurses in Australia do far fewer hours compared to the British nurses, but that's for different reasons. Yeah. And American nurses quite often do fewer still, but they have a national exam. So.
Yeah, I was just going to mention that, Barry. You're definitely speaking to far larger questions, Pete, there.
Oh, yeah.
So I think that's where we'll end off. We're coming towards the end of our hour. I'd like to thank both of you for presenting today. Both the presentations were very informative, unique projects that I personally was definitely interested in, and I hope the audience was. And I think the Q&A session was also very helpful and informative for me, and hopefully others as well. I'd like to thank the audience for attending the event today. All of your questions were very helpful and really guided the discussion and improved the discussion. Going forward, I'd remind people that this presentation will be available online on the Council of Deans of Health website, along with the other resources in terms of blogs and podcasts and other webinars that we've been working with as part of the SIHED and Challenge Funds. So I'd invite everybody to see those and to look at those if they're interested. So thanks once again, everybody. Thank you, Pete. Thank you, Barry. And have a great day, everybody.
Thanks a lot.
All right.